Thank you. Kia ora tātou. Welcome all. Thank you very much, Valerie, for the opportunity of being here. I'm going to do three things in the next 15 minutes. I want to speak about the commitments that we, in the form of our governments, have made to respond to the NCD pandemic. I want, secondly, to speak about priorities as I see them. And thirdly, I want to discuss with you how we are going to overcome the crippling, the scandalous neglect of NCDs on the global agenda. And I've got some personal investment in the story. And the story begins on a very high point, 2011. The first United Nations high-level meeting on NCDs in New York. And what a thrill that was to see heads of states of the world accept the importance of the global pandemic of NCDs. What a thrill it was to see the political declaration from that meeting come up with a wonderful array of commitments that our governments had committed to. That was almost the high point of my last 10 years in this business. Not quite. So following the UN high-level meeting in 2011, WHO member states agreed to a mortality target to reduce NCD premature mortality, that is under the age of 70, by one-third by 2025. The first time we had a global target for NCD mortality reduction, 2012. In 2013, member states of WHO agreed to another 8 targets. 6 around the major risk factors, and 2 around health system issues. And we have shown that if these risk factor targets are met, that the global mortality target on the whole will be met in all regions of the world except in the African region. And especially they will be met if the tobacco target is more ambitious than the 30% reduction by 2025 agreed by member states. That was 2013. 2014 was the second high-level United Nations high-level meeting on NCDs. And this reviewed progress towards the goals and targets. And to be polite, progress had been disappointing. So this time the member states of the United Nations were less ambitious. They agreed on 4 time-bound commitments to develop multi-sectoral action plans, to act on risk factors, and to act on health systems issues, and most importantly, to encourage countries to set their own goals and targets. Trying to focus the agenda. 2015, another high point, Sustainable Development Goals, 17 goals altogether, 169 targets, hundreds of indicators. Goal 3, as we've heard, on health, to ensure health and well-being for all at all ages. A wonderfully ambitious vision. The overall health goal, 3, has 13 health targets, 26 indicators. Target 3.4 is where NCDs come in. 3.4 is to reduce NCD premature mortality by 30% by 2030. To prevent NCD mortality by 20%, and I shouldn't forget, to promote mental health and well-being as well, to an unspecified amount, but presumably by 2030. Target 3.4a is the instrumental target to accelerate the implementation of the Framework Convention on Tobacco Control. Complementing this global set of commitments, there are many related regional, sub-regional, national commitments. And my summary of this part of my talk is that as countries, as an NCD community, we are paralysed by complexity. We have agreed to do way too many things. Dr. Colin Tukiotonga this morning made the point that our governments are only too free to sign up commitments, and he was speaking from the Pacific perspective, yet do very little. So how are we going to deal with this complex set of commitments that we are committed to? Do they mean anything? Well, I think from my limited experience, the answer is to prioritise. And we can prioritise in technical terms, in cost-effectiveness terms, or we can think about our priorities in relationship to the last conversation that we will have had, or the next conversation we will have with the Minister of Health. And a Minister of Health, in my experience, wants to know three things. Will it work? What will it cost, both in terms of money and in political capital? And thirdly, is there a precedent? And in my experience, and I'm interested to hear other people's experiences of these types of conversations, they want it kept simple. Robert, the minister, would say to me, give me one thing I can do this year. I know it's a complex business. I know we've signed up to many, many commitments. I know we need a systems approach. Give me one thing. Thinking about what is possible in the context of every other agenda item on the government's books at that particular point of time. And I should say, while thinking politically, and this comes back to what Ilona was saying, was it yesterday, that we need to be much more literate in our political engagement. I have learnt these limited experiences towards the end of my active career. I do so wish that I'd been taught these things as an undergraduate global health student. So what then would be the three things, and I'm going to stretch it to four with your permission, that I would recommend? And I know this session, Valerie, is primarily on low and middle income countries, but I say the same lessons apply, in fact, to probably most countries. No country in the world that I know of is doing credit to the enormous burden still faced, despite the enormous successes that we've had in many countries in terms of reducing particularly cardiovascular disease death rates. There is still an enormous burden in all of our countries, and we all have very striking inequalities in the distribution of these conditions. So it will be no surprise that my number one priority is tobacco. In fact, I'd like to say that my first, second, third, and fourth priority is tobacco, but I'm restricting it to number one. We have the Framework Convention on Tobacco Control, very exciting moment in 2004 when I was in Doug Betch's office at 2005, Doug Betch's office, and the 40th country ratified. So how is the Framework Convention on Tobacco Control performed? Nothing wrong with the convention. The problem is that we have not taken it seriously. And in particular, we have not taken the most powerful article of the Tobacco Convention satisfactorily, seriously, that is, to raise taxes. The WHO goal is to reduce tobacco consumption by 30% by 2025. We've advocated for a much stronger target, 50% we've written about. And we know that in the first 10 years of the Framework Convention on Tobacco Control being enforced 2005 to 2015, global smoking prevalence went down from 24.7 to 22.2, an absolute drop of 2.5% in that time. 10% drop. Relatively speaking, in 10 years, we need a 30% drop in the next 20 years. We are not, ladies and gentlemen, on target. We need to do much better. Some countries, and of course Australia is a wonderful example, is doing very well, although, and Mike, you might want to say something about this. I understand there might even be a slowing down in the rate of decline or even a levelling off. Whether that's true or not, you'll let me know. But what we need to be doing around tobacco is being much more ambitious and thinking about what, I don't like the term, but thinking about the end game. The New Zealand government has proposed that there will be minimal levels of tobacco consumption in New Zealand by 2025, usually interpreted as meaning less than 5% prevalence. We are not on track, but I think we could very easily get on track if this target was taken seriously. Finland, Scotland, Canada, France, Ireland have also proposed some form of endgame date, some with a plan to get there. Australia's target, I believe, is to be at a 10% prevalence by 2018, although I don't know that that prevalence rate, Raglan, is expressed in any distributional form across subsectors of the population. Our perhaps more ambitious proposal was for a tobacco-free world by 2040. In my view, totally achievable if we were only to mobilise our resources. So that's my first three priorities, tobacco. I do want to say something about improvements in diet. And under this category, I've been quite keen on the salt reduction target. I know that there's some controversies about it, but there's some data at this meeting from Fiji saying that the average consumption is 12, or I think maybe it's 11 or 12 grams per day. We're not going to get into any danger by reducing that down towards 5. Salt versus sugar, I'm a bit conflicted there. My son is an oral public health specialist. He is totally devoted to sugar reduction for the importance of children's teeth, of which I acknowledge. I think I would prefer focus on salt myself, and some people might prefer to be working on alcohol. So I'd say tobacco, one healthy diet target, and then I think there's plenty of scope for the better management of people at high risk of cardiovascular disease. At high risk of cardiovascular disease, maybe 20% over a 5-year risk determined by local conditions. And I'm very keen on the idea of a fixed dose combination pill being used to treat people who have had a cardiovascular disease event or are at very high risk. And this combination pill was under discussion last week at the Central Medicines List committee meeting in Geneva, and I understand it has been approved, but I haven't seen that in writing. In New Zealand last week, MedSafe, our drug regulatory authority, approved Trinomia, a Spanish production, a touch of aspirin, a bit of a statin, and Ramipril for blood pressure reduction. So and this might be a very interesting possibility in countries like New Zealand, but I'm also thinking, and we'll discuss with Dr. Tukia Tonga, the possibilities of this relatively cheap and probably effective medication in the Pacific. Those are my 3 practical priorities for all countries, in fact, but particularly low and middle income countries. And I want to come back to another point made this morning by Colin Tukia. Tonga, the lack of accountability for commitments. The Lancet NCD Action Group, I see Steve Leader here, who's been active in that group, is very keen on independent accountability for global commitments, based on the experience of maternal and neonatal and child health countdown 2015, independent, but with lots of data, lots of measurement, lots of engagement of countries. Countries, of course, hate this. They much rather accountability be done by a slap on the back and a handshake rather than serious data evaluations. And we've been struggling for some time, although I think we're now making progress on what we call Lancet NCD Countdown Project, which will use the available data both on risk factors and mortality to assess the progress that countries are making towards the SDG 2030 target. The last thing I want to say briefly, if I may, I did take my watch off, but I didn't look at it before I started, which was a gesture towards keeping time, but not sufficient. I want to say something. Okay, so we've got a problem. We've heard about the problem in Malawi. We know about it in India and every country in the world, in effect. Yet, and we've known about this burden of NCDs, I guess, since the World Health Report of 1993. And then with increasing sophistication as the global burden of disease and other studies produce data. So we've known about this, and we've had some remarkable successes. We've got some way to go. So how do we overcome this neglect? And I think this comes back maybe again to Alona's presentation yesterday. So we have to recognize the problem, and from Maria this morning, we have to communicate the problem, and we have to do that in increasingly sophisticated, but I would say simple ways. We have to build a movement that is devoted to overcoming what WHO calls the scandalous neglect of NCDs, the gross disconnect between the extent of the burden and the response, WHO's words. We need a movement of UN agencies, of committed countries, of academics, of health professionals, and particularly public health people. And at a country level, and Raglan, you were talking about the importance of community engagement around tobacco control issues. The country level, the concern about NCDs has to have a strong and vigorous community, civil society contribution, because it's only with the civil society contribution power that we will develop, support, sustain the political will which is required to overcome this neglect. And of course, this process will be helped, my view, for discussion if we focus on a small number of selected priorities. Thank you, Valerie.
Thanks very much. Do you want to come?